Oh, it's recording already.
Michael.
They pick the topic and we have to sit here on camera, just the two of us, and talk about it.
Yeah, I know. It's so.
Who got the short straw on this one?
I think you did.
Hey, with friends like you, I just got. Oh my gosh.
That was so funny. Oh my God. I'm so brilliant.
I'm feeling a muscle spasm right here every time we talk. Is that TMD?
Right. I think that'd be terrible Mona.
I would agree. This is my bad joke tension right here that I have.
It could be. Yeah. It's because you know that the one that I'm going to tell is going to be just so funny. You're going to not be able to control yourself. Can I tell you that joke?
We're a couple minutes early. Let's let everybody get on real quick.
Okay. How is the move? Like, are you all settled into? Yeah.
Yep. Finally settled. Thank goodness. New update. I didn't know this was possible, but doing it one stone at a time, my kids and I moved 4.5 tons of slate, river rock, and boulders in my mother-in-law's backyard for a koi pond that had to be filled in. And she showed us the receipt to show us that we moved 4.5 tons of rocks.
That is
at a time.
Oh my gosh.
Yeah.
Wow. Well, you know what happened to me? So I was sitting in my living room, and it goes onto patio doors, and I see these little things on the wall, on one of the walls. And I thought they were like weird bugs, right? Mm-hmm. And I'm like, I wonder what kind of bug that is. Like, I really was curious because I hadn't seen something like that. And there's like 4 or 5 of them climbing up, like just sitting on the wall. So I go outside and I go all the way close to them. They weren't bugs. They were baby flying frogs. I know. I'm like, holy moly, where did they come, right? And then I saw 4 on the one wall around my patio. So I went around the corner to look at the back of the house. All over the back, 20, 25 little baby flying frogs.
Whoa.
Right? Because in Florida, that's where you get them, right? And now, like upstairs on the 2nd floor, I'm seeing them on the bathroom windows.
Hey, so on that note,
yes,
Sherry from Georgia just said what's up in the chat.
Yeah.
So let's pull everybody into this conversation. Everybody, if you are on here tonight, go ahead and hit us in the chat. Tell us where you're tuning in from. We'd love to hear that. And also let us know if you have flying frogs, because most of us don't have flying frogs like Mona does. But yeah, hit us in the chat. Let us know where you're from. We are gonna Brian, you are my friend. Half Moon Bay, California, frogs do not fly here. Or for most of the rest of the country, but there are some parts.
Yeah.
All right.
Oh, only swimming frogs here.
San Diego. Love it.
Wow.
All right. Polly from Seattle.
Oh, Pennsylvania. That's where I just moved from a few months ago.
Don't rub it in. Michael's a nice guy.
Yeah, he probably is relieved that he's not around flying frogs, though.
This is true.
So,
all right. So you all, you didn't come on here to hear about flying frogs.
No.
We're aware. If you did, you were in the wrong webinar. Let's kick it off. We're a couple minutes after. We got a bunch of folks in here, so we want to respect your time. Let me do the standard nitty-gritty stuff. Since it's a CE webinar, you got to know what you're doing with it. I'm Michael Cohen, CEO, founder here at Awaken to Sleep, past trained sleep tech. So when you hear me asking some sleep technical questions, it's itching a certain part of my brain that most people don't have. Apologize in advance for it. We also have the lovely Dr. Mona Patel here. She is tuning in from what part of Florida? I forget.
Palm Beach Gardens, like Southern Florida, where there's a ton of flying frogs.
Tons of flying frogs. So if you all have not had the pleasure of hearing Dr. Mona speak before, a little bit about her background. In 91, she graduated from Queen Elizabeth Dental School, University of Birmingham. That is the English version of the Alabama, Birmingham, just so we're on the same page. And over in the UK. And in 95, graduated University of Pennsylvania Dental School. Guys, she's been doing general dentistry for 30 years, TMD for 10, sleep for 5. She's awesome for a reason. She's here to talk to you about TMD and sleep. Is anybody here, let me ask in the chat real quick, before I hand this off, is anybody concerned about treating sleep patients when they have TMD? Or how do you know who you need to treat and not? Give me a yes or a no in the chat if you would. Okay, we're seeing some of the yeses. Good, then we're on the right page here, guys. All right, so tonight, Dr. Patel is going to talk about Dr. Patel. This sounds so formal, Mona. I'm sorry.
It's all right.
You're amazing, but we're friends. So I'm just going to hand it off to you. Have fun. This is an AGD PACE CE event, so you guys know what it is. You got to stay tuned the whole time. You can see us, we can't see you, but we're going to ask you to put stuff in the chat. If you have questions, please put them in the Q&A section. We will be here tonight until we answer every one of your questions. Dr. Mona's got a lot of great stuff to talk to you about. Stick through it until the end with us. We have a, 12.7 second survey that you have to fill out to get your CE. It will be in the chat, as well as some cool links to articles and the email that comes out later tonight. So without further ado, people didn't come to this to hear me. I'm gonna hand it off back to you.
Awesome. Hi, everyone. I'm just, happy to share all the information that I've computed into my brain. And I know exactly when I first started out in dental sleep medicine, I was just always so worried I was going to somehow harm the patient or, mess up the joints or make them feel uncomfortable, that it stopped me from helping a lot of people because of my own fear. And then, the more I started to do this, I realized that, a successful outcome really just hinges on proper diagnosis. And we do that every day in dentistry. It's really no different to what we do when we are seeing our patients as dental patients. If you stick to that anchor, what is the diagnosis? You won't go wrong with sleep and TMD. And predictability really just comes from minimizing those side effects and really setting up realistic expectations for the patients of, what is their part in this? And we've all heard this phrase, if you inform your patient ahead of time, it's knowledge, it's education. But if you inform your patient after the fact, it's just an excuse and you lose your credibility. So the more information that you can get ahead of time, the more of a diagnosis that you can make and the more expectation that you can set for your patient, you'll look like a genius and you'll sleep at night. So historically, sleep apnea, obstructive sleep apnea and TMD, they were typically diagnosed separately. And as dentists, we tell our patients, you clench, you grind, you box, you clench, you grind, you box. And I'm sure many of you have done this over your careers. I mean, I have done this many, many times before I discovered, the relationship between sleep and bruxing. But here's the thing. You make splints, right? For your patients, 7 out of 10 work, but there are others, they don't. And they come back and the patient's like, yeah, it doesn't work. Here you can have it back. And you just, if you're anything like me, you were like, oh, my patient's so difficult. Oh, they're crazy. And I know that I was wrong there because there was something else. And the continued research and the knowledge just show us that there are questions that need to be answered. Is there a relationship between OSA and TMD? And if so, to what extent are they related? So I want to talk to you a little bit about some studies. This is the OPERA cohort study. And it was a large-scale, multi-center study that followed adults from the ages of 18 to 44 from the start of the study. And this lasted for about just under 3 years. And the goal for that study was to really identify the incidence of first onset TMD and the potential risk factors for development of TMD. And let me share what they found. They found that obstructive sleep apnea signs and symptoms were actually associated with the first onset TMD symptoms. And this was in adults free of any TMD issues at baseline. And both men and women with 2 or more signs or symptoms of OSA had a 73% greater incidence, independent of age, gender, race, obesity, smoking, all of those things. They had a 73% greater chance of having a TMD issue. And in the case control study, chronic TMD was 3 times more frequent among adults with varying levels of OSA. And there's a couple of other studies by Kim and Park in Korea. That was 8 years long. And again, it showed the statistics that primary sleep breathing disorder patients had a 44% higher risk for TMD versus non-sleep disorder patients. And that the incidence rate of TMD was nearly twice as high in these participants with sleep disorders versus non-sleep disorders. Wow. Benetti and Scarano did a study, and their study linked the prevalence of TMD symptoms and signs and showed that they're significantly higher in untreated OSA patients compared to healthy controls. So the other interesting thing that the OPERA cohort study brought up was that between sleep disorders, not just TMD connection, but fibromyalgia, IBS, and headaches. So now we know that there's a link between OSA and TMD. What we do know is that OSA patients have an increased activity in the upper airway as the body tries to maintain that open airway, before it starts to collapse during sleep. And, that all the signals happen in the brain. Adrenaline, cortisol get produced to help that collapse from happening. And when that happens, we get the RMMAs, the masseter gets activated, and you get that little clench forward. And that helps to bring the tongue forward, the genioglossus muscles forward, and the genioglossus muscle actually stabilizes the airway and stops that collapse from happening. Well, that masseteric activation and that clench forward results in bruxism, right? And those repetitive forces constantly exert pressure on the TMJ and its articular disc and the surrounding muscles and the tissues. And we can get painful TMD. We can get non-painful symptoms too. But remember, clenching and grinding activity is about 80 to 100 times more force than chewing. And strain on these muscles from those it's a repetitive injury, right? And what you're going to see is jaw joint noises, clicking, popping, cracking, crackling, episodes of jaw locking, headaches, jaw pain, neck pain. And remember, our bodies will do whatever it takes to breathe, even if that clenching or bruxing activity is going to damage our teeth, create pain and muscles all over our head and neck, or even our joint. Breathing comes first to us. So with all of that connection and knowledge, what can we do? We do know we've got to screen for both when we're presented with a sleep or a TMD patient. So if you suspect a patient is having a sleep issue, or you get referred a sleep patient, you've got to look at the TMJ and do an evaluation there. And if you have a patient who comes to you with pain and it's in their TMD, they have muscle pain, joint pain, headaches, and now even IBS and fibromyalgia, maybe you want to do a screening for sleep as well. And yes.
Sorry, I don't want to interrupt you for the next slide, but before we get through some of the workflow stuff, Robert and Mark both asked for the copy of the studies. I just want to hit this real quick.
Absolutely.
We're going to have a link that goes out to everyone in the email. The CE survey link will be in there. There's another link. Don't miss that. It goes to our website, and every single one of the studies that Dr. Mona goes through tonight will be on there. So that way you guys can grab that there. And then Mona, if you could, your patient verbiage is so smooth in talking to people. What you just went through was so heavy clinical. Can you translate that of how you talk to a fibromyalgia patient, how you would talk to somebody that they, in their mind as a patient, it does not connect to their jaw joint and apnea? How would you talk to them about that? Even if it's a snippet.
Sure. So if I have a patient who is coming in or is in my chair and they have, say they present with primary TMD and they've got noises and popping and, there's a clinical picture of bruxism, I'm going to kind of look in their mouth. And what I like to do, guys, is bring the patient along with me on the story. Because if I just tell them that there's a connection, they're not going to really hear me. So I like to connect one thing in their medical history, one thing in their mouth that might give you an indication of a sleep issue, and to one thing how they're feeling, right? So when I will look in the mouth and I'll be like, wow, Mike, it's great to see you. You're in my hygiene chair. It's been a while. Looks like you're still on your hypertensive medications. And I see that you have, how's the fibromyalgia doing? How are you feeling? You still aching, or are the meds working for you? And then I'll do my examination. I'm like, Michael, I just realized I noticed this. There's a lot of wear on your teeth. And, I'm noticing it now because I've learned all these amazing things about whole health and connection, and this is going to sound a little odd, but do you notice if you're clenching during the day or at nighttime? And usually my patients will know. And if Michael says, I kind of think I do it at nighttime because when I wake up, I feel uncomfortable. It gives me a way to connect everything together, where I'll be like, hey, so if you're feeling like your muscles are tight in the morning, can you tell me, do you feel actually like you're getting a good night's sleep, or is that kind of affecting your sleep? And again, you'll be surprised the more and more you do, the patients open up quite readily when they want to talk about things like that. And, if Michael says, yeah, I don't feel like I wake up super well, refreshed. I kind of feel like I need a couple of cups of coffee during the morning to get me going. I'm like, that's so interesting, because there's actually a huge connection with people who clench and grind, who may have some discomfort in their jaw joints with sleep. If your sleep is disturbed and you're clenching and grinding, and you might have something called sleep bruxism, it can affect your health. And one of the ways it can do that is it can be associated with fibromyalgia. It can be associated with hypertension, which I see that you have and you're on meds for it. Have you ever been tested for, having a sleep issue? And then we'll talk about what the doctor says, etc. So hopefully that helped. Is that what you were looking for, Michael? Hopefully.
Thank you. Yes, that was solid. Thank you very much.
Perfect. So, how does this affect your day-to-day workflow, right? What would it look like? So remember one thing: when you start doing dental sleep medicine in your practice, no matter where your patient comes from, right? And what does that mean? It could come from a sleep MD. It could come from an outside referral from a patient or other dentists, or it could be in office where you've been screening and testing your patients and getting the data read by a sleep MD, right? But once you have these patients in your office and someone has prescribed a MAD, mandibular advancement device, you've got to get your protocol down. First, remember that you have to confirm that they're good candidates for a MAD, teeth-wise, perio-wise, retention-wise. But also then, please add evaluating the TMD. Because if you do that and you get a diagnosis of how that joint and muscles, that whole apparatus for the patient is working, you now can confidently go to the next step. If you diagnose that there's no TMD from that TMJ evaluation, okay, fantastic. You can now proceed with your sleep protocol, make them a MAD, do your, efficacy tests and all of that. But then when you bring your patients back to reevaluate for the improvement of the OSA, make sure that you also document the TMD health, make sure that they're doing well. And I also firmly believe in really great follow-ups. So one of my pet peeves, and this is a little bit of a tangent, one of my pet peeves when I started to treat sleep was that patients were given a CPAP for years, 10 years, and nobody ever followed up on them. Or a dentist gave them a sleep appliance for 7 years, but the patient didn't go back or didn't get followed up on. And so I firmly believe in a strict protocol, and I teach about that, but I really like an annual checkup with all of my sleep patients. Number one, not only to see how they're doing with sleep, but to also evaluate the TMD. And if there are concerns about it, retake imaging that I may have originally done to follow the health radiographically, okay? Now, fantastic if they don't have any TMD, right? You can go right to your sleep program and fantastic. But if there is TMD issues, get a diagnosis, follow your appropriate therapy. Decide if this is a patient who needs a daytime appliance. Their nighttime appliance will most likely be a MAD. And then let's do your follow-ups depending on your treatment protocol. So my TMD sleep patients are going to come back way more often during that initial delivery, after the initial delivery of the appliance. I want to make sure that they're doing well, that there's no discomfort, because I want them to wear that appliance to protect them at nighttime. I don't want them to stop wearing it because their muscles or jaw joints are uncomfortable. But knowing that there's a TMD patient that is requiring a sleep appliance, it also helps to know what type of appliance I might choose. Do I need to do one that has smaller, more finer adjustments? Now, what if you have a patient that comes to you totally just for primary TMD and sleep is not a perceived issue? So what do you start with? We always start with a history, and then we look at our examination. And during that history and health history correlation, look for those signs and symptoms or medications that are involved with sleep. And with your examination, include a sleep screening. Look at the back of the mouth, look at the throat, look at the tongue, look at the wear on the teeth. And if you suspect a sleep disorder, your diagnostics must include testing for sleep. Okay? Just make sure that you're telling the patient why. And I like to use the verbiage of, I want to eliminate sleep bruxism. You could be stressing your joints and muscles at nighttime, and that clenching or wear on your teeth is creating a lot of stress on your joints and muscles, and now you're in pain. And I want to make sure that you're not doing that because of a sleep issue, which is called sleep bruxism. I keep it very simple for patients, and I'm like, I need you to take this test to eliminate that, because I'm going to need to prescribe you a treatment plan. I'm going to need to prescribe you appliances and orthotics, and I need this information to make sure that I prescribe the right appliance for you. And, using that verbiage, I've really not had any patient not want to do the sleep test. And for those of you who really are getting into dental sleep medicine, having a home sleep test in your office to be able to eliminate sleep bruxism so that you're able to prescribe the right appliance it's gold, okay? And once you do your diagnostics and you've got that sleep data and it's been read by a sleep physician, if you have a patient who's positive for OSA, but also has primary TMD, you're going to follow that treatment plan for that diagnosed issue. You're going to treat the pain, and it could be with aqualizers, it could be with injections, it can be laser therapy. You're going to decide to do a daytime orthotic and a nighttime orthotic. You're going to have a different protocol for follow-ups. You're probably going to see that patient weekly to keep an eye on how they're doing. Your therapeutic bite is not going to be a George gauge bite that you do for dental sleep appliances. You want to put them in the most comfortable position, and that's usually the phonetic bite. And if you have a primary TMD patient that has taken your screening and they tested and it was negative for OSA, great. Now you just follow your TMD protocol. So there are side effects of MAD therapy that, also affect the TMD. And like I always say, the best way to deal with side effects is to minimize the possibility of having them. So there's a study by Perez, and they took data from 167 patients, and they were evaluated at baseline. And 159 patients came back after 118 days, that's visit 2. Then 129 patients came back after 208 days, visit 3, and so forth to visit 4. And they evaluated the presence of TMD symptoms through a questionnaire. It was consistent. They followed great criteria for that. And they also, in addition for TMD, they also did a clinical evaluation for the presence of posterior open bites. And the results of this study are very heartwarming and very confidence-giving. So the results are that the use of these MADs can lead to the development of TMD in a small number of patients. However, these signs and symptoms are most likely transient. And patients with pre-existing signs and symptoms of TMD did not experience worsening of those signs and symptoms with the use of a MAD. And would it interest you to know that they actually can decrease over time? And that's what happened to me personally when I actually developed a horrible TMD issue on my left side. And I could not talk to patients without I was literally treatment planning and talking to patients, massaging my joint here. And then I was diagnosed with mild sleep apnea. Kind of followed the studies, right, that we went over. Well, anyway, I treated myself, made myself a MAD, and that's really what kicked off my journey, by the way, guys. But I treated myself with a MAD, and within 2 or 3 weeks, I realized that I did not have any pain here. I felt so much better. I was comfortable, no muscle pain, and my range of motion got better. So that's heartwarming, right? It gives you confidence. Posterior open bites were found to develop in only about 18% of these patients. And 28% of those 18% were aware of the bite changes. And I know that a lot of fear happens when we think about bite changes after oral appliance therapy. And there's ways to manage that. And again, that is to avoid that happening in the first place. And so a really great clinical protocol and holding the patient accountable for that and what they have to do on their part is super important to minimize the posterior open bites.
So, Dr. Mon, quick
yes.
question on that real fast. So we've covered this a little bit before. You've covered that topic briefly about posterior open bites and some of the open occlusion.
Yes.
That obviously flies in the face of everything important as a GP. So yes. I know we're presenting the sleep side, but for the rest of our audience, I'm going to kind of play devil's advocate. Okay. Instead of saying what's more important, chewing or airway, how would you were a GP that also practiced sleep and treated TMD. So how would you handle that if it bothered the patient or didn't? Just to kind of answer that part.
Actually, it really doesn't bother patients. They won't notice it until they go somewhere else and someone points it out. Or if they were a patient who came to you only for sleep, but had their own dentist, and then the dentist is doing restorative. So again, I in my clinical protocol actually identify open contacts and holding contacts between all of the teeth. Because you know that not every single tooth meets unless you've been equilibrated, right? Mm-hmm. And you have patients, and so if there is a patient, I explain it this way. I say, listen, an appliance wearing it long term may cause changes in your bite. You may find that some of your back teeth don't meet as they used to. We want to minimize that. We definitely want to avoid that. We want to minimize that. And your part is wearing a morning aligner and doing these exercises. And if you notice something is different and your bite's changed, your job is to call me straight away, because the longer you wait, the harder it's going to be for me to figure out how to correct it.
Awesome.
Okay. Cool. And then what I will also tell patients is, so, I would rather sleep well at night and wake up feeling on top of the world than have my teeth meet. Because my teeth meeting or not meeting doesn't stop me from eating or chewing. In fact, when I eat food, there's food between my back teeth, so they don't actually touch anyway. How do you chew your food? And they get it. So hopefully that helps. So I wanted to quick mention another study by Benetti. This was a meta-analysis of 12 studies that really evaluated the TMD prevalence on adult patients wearing an MAD. And what they found, again, yes, you can celebrate. You're not going to hurt people. You're going to be fine. Great news. TMD issues are not a contraindication for treatment. However, diagnosis, follow-up, staying in contact with the patient to monitor is what you need to do. But their second finding, what they also noted is that symptom-free patients may develop TMD. So people who never had issues or pain before, and you put them in a MAD, may develop TMD. Now, they didn't say why, but I'm assuming it's the possibility of a misdiagnosis of a prior TMD condition. Maybe they set the bite beyond the capacity of joint muscle issues, and so I would say that information is lacking. What I found in my experiences, if there was someone who had no issues before, and then they wore a sleep appliance and they started to develop discomfort, it's because I missed something on my examination. And I will always go back to that. Or I didn't miss something. I told my patient to start to doing exercises and stretching and my functional therapy, and they didn't do their exercises. And so they were putting in this appliance in already a system that was still contracted and, compensating for the bruxism. So what we can do, right, and what they would recommend is to really do a comprehensive clinical examination. Note the mandibular movements. You're looking for deviations, deflections to give you signs of joint conditions, noting TMJ noises during movements, doing a muscle and TMJ palpation, and getting all the baselines for the health before that appliance therapy for sleep, and then also documenting your diagnosis. So let's go to the comprehensive clinical exam. And this is kind of a brief overview of how I do mine. I do have a really detailed way of going through a records appointment that actually identifies a lot of red flags, but this unfortunately is only like a 45-minute to an hour webinar. But if you want more information on that, I'm sure Michael and Chad can give that to you after the webinar is finished. So the history is super, super important. For those of you on the sleep journey, you've heard of Jamison Spencer, you've heard of Mayor Patel. They're amazing guys who've trailblazed sleep and TMD. And my favorite saying that they have is, the mystery is in the history. You talk to the patient about everything, you'll uncover so many things. You got to ask about clenching, grinding, daytime, nighttime. I like to ask about major traumas, car accidents, whiplash, direct hits to the jaw, with even when they were children. Are they wearing a CPAP? Are they wearing it with an appliance or without an appliance? What's their ortho history? And I also bring in a sleep apnea connection if they don't think there's a sleep issue going on. Okay. Remember, there are 4 reasons that we're bruxing: sleep disordered breathing, stress, side effects of SSRI medications, and the joint stability and muscle stability. So what would you do on your examination? You're going to palpate the joint, right? You're looking for retrodiscal inflammation. And discomfort is usually an inflamed disc. And what would you want to do with an inflamed disc, right? You want to relieve the pressure off the disc. You want to kind of take the joint a little forward and a little down maybe, right? To help that disc inflammation resolve. Well, guess what a mat does? It does the same thing, right? You're taking the joint off the disc. So again, as much as we think, oh, we have a patient with TMD and maybe we shouldn't do a sleep appliance, in actuality, you're helping them as long as you do it within the parameters of what their muscles and joints can handle, right? And that's where you decide on what type of bite you want to take, right? If you go right into a George gauge or vertical and protrusive at the same time, which are great on healthy TMD patients, maybe that's not going to be a comfortable position for someone who's TMD sleep and symptomatic. Maybe you want to do something like a phonetic bite. Okay. I also like to do joint noises. I have listened to joints with a stethoscope. I also I love using a Doppler. I get one from Amazon. I think it has to be over 200 hertz, and you just get like a whole big bottle of that gel and you put it on the patients and you listen for those noises. There's also from BioResearch a great tool called the JVA that can give you really specific readings on the joint and the disc. And I make a note of those noises, because you have to also remember the absence of a joint noise does not mean the patient's healthy, not necessarily. And that's where the history comes in. Please, if you remember anything from this webinar, write it down, guys, please. Remember always to ask your patient if they've had a previous history of joint noises. And even if they remember as a teenager and they're 50 years old, or did it happen after ortho, make a note that they had joint noises at some time and they disappeared. And we'll get into that later, but it's super important that you do that. And once I've done a basic TMD exam, I'll do my basic muscle palpation. Now, if I'm noting that this is a TMD patient, I'm going to do a much more in-depth muscle examination, and I'll actually charge for it as well. Like I will charge out a TMJ comprehensive examination for a patient. And when I do a muscle palpation, I like to keep it simple, and I like grading. 0 is nothing. Number 1 feels good, as in that massage, it feels like a massage and it's releasing tension. Number 2, not great. And 3, don't touch me. And the pressure on the muscles are like, when the amount of force that you put in when you're blanching your fingernails. And why do I do this? Because here's the thing, if they have sore muscles, I want them to start working on exercises before they even come back for the delivery. When they leave after I've taken my records, they're going to start doing these exercises, because that's going to help them accept the appliance a lot better in 4 weeks. It also helps me determine if I want to add a discluding element to my sleep appliance. And if you have someone who has discomfort and you note it, and then you're doing a follow-up on the muscle and TMD after the appliance is placed, you can then see how they've improved. And, again, validate your therapy to the patient. Okay. I also do range of motion. So I use a great little ruler. It's called the Therabite ruler from Great Lakes. A normal opening can range anywhere from 32 to 70. And obviously men open wider than women. And I think the taller you are, apparently the wider you open, right? And that range of motion of maximum opening can decrease with age. But one of the reasons I find that's important is if they came in with a really small ROM, but not uncomfortable, I want to look more into, is there something going on with the joint? Is something happened with the disc? And also it influences what type of appliance, what type of mat I'm going to use, because if they've got a limited range of motion, I want to be able to give them something that's easy for them to put in. I also like to look at the lateral range of motions because, again, if you have someone who goes to the left 10 millimeters and someone who goes to the right 9 millimeters, that's fine. But if the number's like 9 on one side and 5 on the other, that's a red flag again. And these patients may not have pain, but when you see such a difference in the lateral range of motion, that's when you stop and you ask them if they ever had an issue opening, they ever locked, if it never came up in your initial history, this is the time that you can delve into it. And you know what? That's when the patient might go, oh, you know what? Years ago, I remember there was a time when I couldn't open, when I had this, I yawned really wide and suddenly I felt like I was locked in. And it hurt for a little bit, but then it went away and I thought it was fine. So this is where the history is super important. Remember to check for your deviations and deflections. They move towards the compromised joint. And look at your midlines in MIP when they're biting down. I always say, take a look at the midline when they're biting down, take a photo of it, and then have them protrude. And if their midlines are off, make a note of it. Because when you take your bite record for a patient, if their midline is centered when they're in MIP and you take your bite, you want to make sure that your bite mirrors that your bite's centered, that the patient hasn't gone off to one direction. Now, what if their midlines are centered when they're biting down? But then when they protrude, maybe their midlines go to the left a little bit. Again, take a photo of this. I like to note it down because when I'm making an appliance for them, I will mimic that in my bite capture. I'm not going to try and swing that midline back to the center when it normally wants to go to the left on protrusion. Because if I do, I'm creating a torque on the muscles, on the joint, and I'm going to create discomfort. So I'm actually going to create a side effect with my MAD. So super important. That's another thing I'd love for you guys to write down. So if you ever have patients who've come back, you've inserted a MAD and they're uncomfortable and you can't figure out why, take a look at the midlines and make sure that the midline in MIP without the appliance mirrors the midline in the appliance.
Hey, Dr. Mona.
Yes.
So we got a couple of questions that I'll merge together. So
okay.
One is, how often is what we're calling TMD actually a muscular issue instead of a joint issue? You were kind of alluded to that.
Yeah, and pretty often. And again, a lot of that is this comprehensive examination that will allow you to identify if it's purely muscle or if there's some TMD stuff going on. Again, I'm not here to teach a TMD course, but I'm helping to identify the things that you could do to be able to move forward confidently. Yeah.
Got it. And then the kind of part two to that, if you're titrating the MAD forward,
yes.
If it's too far forward or too fast, how do you resolve the perceived TMD pain or maybe muscular issues that arise from that?
So I always, if I've protruded an appliance and titrated it forward, the first thing I do is if a patient comes back with discomfort, I'm going to look at my midlines. I just want to make sure that I didn't create that. If there is discomfort and I had picked up on muscle or joint issues at my records appointment, we'll verify that the patient's actually doing their exercises to help with that. And 8 out of 10 times they've been lazy and they're not doing their stretching, the myofunctional exercises, their tongue. So that's, an easy way to fix, right? But if none of those are what's going on, and then it's most likely that I've protruded too quickly, right? So hopefully at that time I've chosen the right appliance that allows finer movements. So I love ProSomnus. That's one of my go-to appliances. And I love the switching in and out of trays. But if I know on my records appointment there's some muscle or joint issues, I may not want to do that type of appliance. Maybe I'll choose to do the ProSomnus Herbst, which has fine-tune, like you can adjust that appliance 1/10 of a millimeter with one rotation, as opposed to the Evo, which is 1 millimeter.
Yeah.
Right. So this records appointment and this information gathering is going to help set, number one, you up for success because you're going to choose the right appliance. But if by any chance you've chosen an Evo and it's, you've put it in, you've taken a bite and you've put it in and they come back and they're sore, one of the things that you can do is work with them with muscle exercises, myofunctional therapy, all of those things. But if they're still uncomfortable, then you can call ProSomnus, and I've done this before, and they've made trays negatively. So if I'm, at L0 and lower 0 and upper 0, as ProSomnus works, right? And I put it in if my patient's uncomfortable, they will be able to go back and make a -1 and a -2. And then we'll start the patients off in a retruded position, letting them know until their muscles or joint gets used to this position, we're not going to be able to walk them forward to what we feel is our ideal therapeutic place.
Cool.
Hopefully that helps.
Yeah.
Yeah.
Great.
Any other questions, Michael? We're good? Yeah. Okay. So remember, points to consider, joint noises. I really alluded to that, and this is why. So when you have noises and then they disappear, patients perceive that as being healthy, right? And because the noises have gone. So if they've gone, I'm okay. But in reality, when you start to get noises, what does that mean? When you're opening and you get a noise and a click, it could mean that as that joint's moving out of its home, you're popping off the disc, and that's the noise. And then when you go to close, you could get noise when you pop back on the disc. It's almost like you have a partial disc displacement, right? And then when the noises disappear, that usually may indicate that now you've got a complete disc displacement. And why is that important? Because when you start to wear an appliance like a MAD, that's actually going to help with everything. You may possibly recapture the disc a little bit. And guess what? When you do that and you recapture it, those clicking noises can come back. And you know what? The patient's going to come in and they're going to say, oh, this appliance is not working. The noises are back. And so if you know all this ahead of time and you let the patients know that their perception of no noises may actually be no disc between the base of the skull and the joint, and that they're bone on bone and they're harming their jaw joint, that no noises with the information that you have might not be great. And if the noises come back, that's actually an okay thing. So now let's look at the possible side effects in the joint and muscles after we start the therapy, okay? So causes, you put in a MAD and suddenly there's discomfort. It could be that there's posterior contact that's heavy on the painful side. maybe you've advanced too quickly. And so now, hopefully, we've chosen an appliance that allows us to retreat back. Unfortunately, not all appliances do that. I know that the ProSomnus Evo IA Select, you can ask for negative trays, but if you've made a Herbst, your start position is your bite position, and you really can't retrieve that, unfortunately. So again, identifying all of these factors in your records appointment with your comprehensive examination will really help to minimize making a new appliance from scratch. And, you know, again, if you've titrated an appliance and there's discomfort, you might have just titrated a bit too much, bring it back. Also, just check that when you titrated that appliance, if it's something like a Herbst, you adjusted it equally on both sides. Because, and ask me how I know I've done this, and that happens to the best of us, is what I say. You can take an appliance and you know that you're going to titrate it and you're going to do 5 turns on one side and 5 turns on the other. And then you're doing the turns and the patient starts talking to you and you start talking to the patient and you forget to change over and you do the 5 turns again on the same side. And suddenly you've created this talk and the patient gets uncomfortable. So when a patient comes back after wearing an appliance and you've titrated it and they're uncomfortable, just double check either side that they're equal, okay? So, you know, and the other part is that the midline, remember I told you if they have some pain, it could be because the midlines are not, you know, lining up. What can you do? If it's a heavy contact, adjust your molar pads, walk the patient back if it's possible, very slow advancements, and patient exercises for sure. And this is what I mean by the midline. So this is one of my patients, and you know, when he's in MIP and edge to edge, you can see that there's a midline shift. And so when I captured his bite, in this picture, you can see that the midlines became equal, and he came back uncomfortable. So I actually retook the bite and had to reset the appliance. So myofascial pain and headaches are, you know, myofascial pain can present as headaches. And again, the cause of myofascial pain, sore muscles, you'll have a dull ache, you know, that's why that muscle exam is super important. Stretching exercises, moist heat, NSAIDs, muscle relaxants. But the best thing to do is just get them started from day one. And I like to tell patients like, hey, you know, your muscles, they're probably not going to be ready to accept this appliance unless you do these. It's very similar to if I went to walk for 3 months, if I walked 5 miles every day for 3 months, right? I'm going to be fit, healthy, my legs are strong. And the minute I stop walking and I change that exercise to lunges, I'm going to be sore because I'm using a different set of muscles. And that's the same thing that's happening with your jaw muscles. So if you start to exercise now, it's going to make it so much easier and much more pleasant for you to be able to start wearing your appliance and feeling great from the get-go. And if you go on to the AADSM website, they have great videos for exercises. They're also on YouTube. And what we did is we just downloaded them in every room on our computers, went through the exercises with the patients. And again, this is not me doing it. This is my sleep queen. She would make sure she would go through the exercises with the patients so they knew what they were doing. And then she would just forward them the link of exercises to their phone so that the patient had it and were able to do it. So hopefully this gave you a little bit of confidence and comfort in knowing that if you have someone with TMD, you actually should go ahead with your sleep protocol if you've covered all your bases with your examination and your diagnosis. And hopefully I gave you some red flags to be aware of and to be able to, feel confident going forward.
Incredible.
Oh, I forgot that this played. There you go. So you can watch this at your own time, guys. I would really advise you to have your team watch it, and whoever's presenting the, doing the delivery, your sleep coordinator, sleep champion, sleep queen, sleep navigator, whatever you want to call them, your sleep person, make sure that they're really familiar with those exercises.
Cool. All right. So Mona,
Yes.
we have 25 questions.
Oh, okay.
I'm going to do my best to matriculate those, but you got up on the slide here. So we do, if you guys have been on our webinars before, we try to give back to you as our community. We do monthly courses. We've got a course coming up this weekend. So what are you doing on Friday? That's the question. This Friday and Saturday, we have a course that is available up until Friday at 8 a.m. when the course starts. It's $400 off. So if you guys want to show up for that, I'd be happy to have you. Oh, Mona, can you share your screen again?
Oh, yeah, sure.
So if you guys want to register for that, it's awakentosleep.com/events. No coupon code needed. Just hop on there and book it. You guys won't regret it. You can bring your team, up to 4 people with each doctor ticket. So if you need help with implementation, that's the course. The other course that we have that answers a couple of the questions. So a couple of folks said, hey, what exercises, what do you put in your plan for myofunctional therapy? And how do I get more information on going through the detailed part of this clinical exam? I'm summarizing big time here. The answer to that is Dr. Patel does a 1-day clinical hands-on course virtually with Awaken to Sleep. It is completely different than this course, but you will find it on the same page. So if you go to awakentosleep.com/events or hit that QR code, it'll take you there. You guys can check out the Clinical Foundations course. Again, if you guys want more information, it's there and available. Let's get into, there was one other one. I'm going to address it because you got the slide up. The title is different of this course. Level Up Your Dental Sleep Practice. We used to call it Starting Your Successful Dental Sleep Medicine Practice. And the truth is, many of you have started and hit hurdles, whether it's payment or complications. This is not necessarily a beginner course. This is your implementation course. So that's a little bit different title change. So for those of you that didn't know that before, no big deal. This is the brand new course. So lots of verbiage, lots of tactics. Mona, can you go to the next slide real quick? We'll cover that.
Oh,
and then
hold on one sec.
Finish up on the questions. If a course...
Did it move?
Nope.
All right, you keep talking, I'll get it.
Okay, I was just going to say, if you guys are not in a spot, anybody on the webinar is not in a spot where you need a course, or it's not this fits, this peg goes in that hole kind of a thing, and you got some burning questions, as sleep coaches, we've got sleep coaches that'll do a free consult, not a sales pitch, a true consult, answer your questions, give you some direct feedback on what to do and how to fix things. That's free, and it's always free. It's on our website, /questions, or use the QR code. And we've got the next slide that has both of those if they want to do the QR code. Wow. Okay, Dr. Patel, Dr. Mona.
Can I stop the share?
Yeah, you can stop the share.
Okay.
Holy cow, there's a lot of questions. First one, can you restate what you said earlier about the difference between education and excuses?
Yes, this is one of my anchors for me to always remember, and I hope this helps you guys. But when you inform the patient ahead of time, right? It's education, it's knowledge, you're informing the patient ahead of time, and when it happens, you're a genius. But when you inform a patient about something after the fact, after you've inserted an appliance or done something, it's just an excuse, and you just lose your credibility. So I'm really about identifying red flags. I sound like a broken record, but I like to identify issues, and I actually like to put the accountability on the patients and let them know, document it. But when it happens, just like I said it might, I'm like, awesome. Yes.
Yep.
Yeah.
So important. Thank you. Okay, so Abby asked, is the doctor, dentist, the one who's responsible for the clinical evaluation, just confirming, or in a calibrated workflow, what part are you as the doctor doing versus the sleep champion is doing?
Yeah. So what I like to do is when you've got your sleep champion trained up and really like on par and with comfort, all of the things that we do, such as a basic TMD, muscles, our range of motions, all of those things, that's information gathering. That's data gathering. If you have an amazing rockstar team member, you train them to do that, they can information gather. But their responsibility is to impart all that information to you when you come into the room. And you need to be responsible to putting on your listening ears and not have your head back in the restorative procedure that you left or the hygiene check, but you have to know what you're listening for and what is your aligned action to your sleep team member to go over with your patient.
Awesome. You talked about posterior, actually, hold on. We are at the 6 o'clock mark. If you all just came for the CE, your survey is going to be in the chat, or it's going to be in your email exactly 1 hour after we end this webinar. But if you came for the content and the learning, we're going to stick around and answer a whole bunch more questions. So it's in the chat there. If you want CEs, if you want to schedule a call with a coach or go to the discounted course, it's all right there because somebody awesome put it in there. Thank you guys, team on the back end. Okay, posterior open bite. We talked a bunch about that. You talked a bunch about that. What causes what's the actual cause of the posterior open bite? Is it due to changes at the joint position or extrusion of the anterior teeth? And pair it with another couple of questions. How do you treat it? What do you do and when? Right.
So changes in the posterior, occlusion, that sudden change could be changes in joint position. Inflammation goes away and suddenly you've got an open bite. Diagnosis, knowing what the cause is before you start stepping in and treating it. In, super eruption of anterior teeth, possibly, but not with sleep appliance therapy, because remember, those appliances are so rigid and they act like splints, right? They're not going to allow tooth movement and extrusion. Could it be posterior open bites can happen if the patients are not wearing their morning aligner? And so the lower jaw likes to be in that position and you get some remodeling of the jaw joints. Yeah, that could be. How do you treat it? It depends. If it's being picked up early, is there a way to reverse it? Is it a long-term, posterior change? Like I had a patient who had a MAD made by someone 7 years ago, and then she came to my office and she was class 3, but her front teeth were all had chipping and wear, and I couldn't figure it out. I couldn't make her teeth move, in that way. So it really depends on the treatment of a posterior open bite. Could be nothing, but then it could be based on how long it's been like that.
Got it.
Yeah.
Okay. Thank you. And I guess last one on posterior open bite, I forgot to roll this one in. How likely is it that a unilateral posterior open bite, how likely is a unilateral posterior open bite if you recapture the disc on one side?
And that's a good question. I have not come across that, and I don't have any data to give you a solid answer to that. But if Michael, we could get the name and, I'll do some research and get in on that.
Okay, cool. Well, it's like you said, we got 45 minutes to an hour tonight, which is going to be over an hour. We'll keep plugging though. Somebody asked, they've had a patient in an MAD for 7 months. Regular dentist is telling the patient that she has a new deep perio pocket on number 31 and is blaming the MAD. Is this possible? And have you ever heard of an MAD causing perio issues?
I haven't heard of a MAD causing a localized perio issue. So, again, it has to go back to what did that bone and perio pocketing look like on that particular tooth before the appliance was put in, and comparing your radiographic images and your perio charting from that time to now. And then checking, when you put your appliance in, did you have to do any relieving? Did you change something on the anchorage? So there's a lot of factors in that. But I would just start with what was the original presentation compared to the presentation now, and see and go from there.
Got it. Cool. Next one, how do you build in the mandible deflection on an oral appliance? Or it depends on the type of the oral appliance.
I don't understand that, but are they talking about the midline and the deflecting and aligning it up, or are they talking about a discluder?
We've got a couple other questions about discluders. I think it's the midline shift.
Midline shift. You don't build in a deflection a midline shift into your appliance. Real quick, what you want to do is not create a torque on the patient's joint and muscles. So if a patient, like for me, when I go forward, I actually my midline shifts to that way. So when I'm going to take a bite record on myself, I want to mimic that. Right? I don't want to bring my lower jaw midline to center with my upper to make it look perfect, because it's going to create a torque. Yeah.
Got it.
And I hate to be obnoxious or cheeky, but here's the thing: if you take my clinical course, you'll get much more information on that compared to this 1 hour.
For sure.
So, yes.
Okay. So somebody asked how fast do you titrate the protrusion weekly, or it depends. I'd say short answer, yes, that's in the clinical course. Can you give us a short snippet for that?
Sure. I mean, I always start with a 24-hour phone call to see how the patient did on their first night. Okay. And then I will do a 2-week in-office follow-up. And then depending on what the patient is doing, feeling, what they're quantitatively feeling with their pain points and all of those things, will determine when I actually go ahead and do my titration and all of those things.
Cool. Thank you. If you want the detailed stuff, you know where to go. How do you determine exercises that you recommend and resources you refer to? You already pointed people to the AADSM site for that.
Yeah. I do have, I've collected a few exercises for myself to give patients, like a lateral stretch and masseter stretch. Any YouTube videos, and do type in a lateral pterygoid release, masseter release, you'll find those. And like I said, you can have them, you can type them out, or I find that people are so visual. Mostly we are all visual in our learning. You'll have some auditory people, some kinesthetic people, but usually it's visual. So if you have videos from YouTube, send them to your patient through RevenueWell or Yappy or whatever, but they'll have them on their phone. But the most important thing is to make sure that your sleep queen actually sits with the patient and shows them how to do it.
Yep. Yeah, don't send them to YouTube without telling them how to spell pterygoid.
Send them the actual link of it. And then as for myofunctional therapy, there are some great myofunctional therapists who actually have their own offices. I would look for them in your local area and start building up a referral base. They are amazing at helping, again, strengthen the positioning of the tongue. Strengthening the tongue makes such a difference in outcome for sleep. Because if you have a stronger tongue, and it's basically going to help stop that collapse. they're connected. So yeah, local networking with your myofunctional therapist.
Cool. Anything, another question on the exercises, is there anything different you would do for TMD patients versus your MAD patients?
You know, it really depends on the diagnosis. If there's muscle pain, it's going to be a lot of muscle work, muscle release. For TMD patients, it depends if they're in pain. I'm not going to have them do so much. You know, I've got to get them out of pain. I've got to be very palliative. Yeah.
Got it. Have you had good results with your spray and stretch techniques?
Absolutely. They're great for relief and they're great for diagnostic capabilities too.
Cool. Okay, so anterior deprogrammer, NTI, morning repositioners, how do you handle this? When do you add an anterior deprogrammer?
Yeah. So, you know, yeah, usually discluding elements I'll want to do in those clenchers, you know, headaches. But one of the pitfalls that I will tell you to do, this is another red flag warning. 20% of the population do not benefit from any discluding elements. So this is a quick way to quick check. So have your patients bite down on their back teeth, clench their muscles, activate the masseters, and see how much force they're putting in. Then slide to the front teeth together and see how much muscle activity reduces. They've got a reduction and you've got a clencher, you've got headaches. Maybe that's where I would put a discluding element in. But if there's no difference or it gets worse, stay away from the discluding element.
Okay, for real, how many of you that are still on here actually did that when, like I did, when she said, okay, bite down and then move it forward and bite?
Did you notice a difference?
Yeah, I did. Thank you, Abby. There's two of us. All right. So, okay, for real, a ton of people did this. All right. It's not just me. Funny question. Who would win in a wrestling match between me or the Ultimate Warrior? That's a dumb question, Jason. Me, because he's like 82 if he's still alive, right? Just
Wait,
kidding.
that reminds me of my joke.
Oh, no. Oh, no. Go ahead.
What did Mike Tyson... Well, Mike Tyson and Chris Helmsworth, imagine that they're working out in a gym and they're sparring with each other. And Mike Tyson's really making Chris work for his money, right? And they finished and they said goodbye. What were Mike Tyson's parting words?
I have no idea.
You'll be poor tomorrow.
For those people that died just like me right now, I don't even know what to say. I'm going to try to call in reinforcements in the chat and it's not working. Oh my gosh.
I hope I got a lot of laughs there because I think that was hilarious. All right, moving on.
Difference between the phonetic bite and the George Gage bite.
Oh, such a big difference. So phonetic bite is more of a neuromuscular bite. When you take a phonetic bite, it is really to get your patient in the most comfortable place. It is to do with watching the patient count through the 60s through to the 70s. And there's actually Apex Dental Lab in Burbank make these little phonetic jigs. And you can then pop it in there and take a bite registration. But if you came to the clinical course, I would teach you.
I'm not reading Tony's joke. Do not read the chat.
Wait.
It's getting late. I know CPAP actually causes bite changes. Can CPAP cause TMD in any way?
It can. It can. Yeah. You know, the CPAP based long-term CPAP wearers. So again, that's why I always say, you know, mystery in the history. Well, I don't say it. Jamison Spencer did, you know, and I just am impersonating him. Basically, history, questions, CPAP. I actually do believe a lot of CPAP wearers should be wearing some kind of appliance.
Yep.
Yeah.
For sure. Okay, so what's the code for a TMJ exam? Do you send it to medical or dental? I'll answer the medical side.
Yeah, you do the medical.
Medical, there's a whole variety of E&M evaluation management codes. It's going to depend on what you're measuring. Did you take vitals? All of the stuff. Did you meet the criteria? How long and what systems are measured? That's not an easy answer for tonight. I'll let you answer the dental side. Do you bill it to dental, and is there a single code that you normally use for your exam?
I do a dummy non-insurance code with a private fee.
Cool. Mechanism for the negative effect of PPIs on OSA.
Great question. I don't think I have enough information on that.
Okay, cool. How does VDO play into this? I'm not sure what this is, because that was asked a little bit ago.
Yeah, VDO, the vertical dimension. I mean, it really depends. Like I said, you know, again, with TMD, if you have an active TMD patient who's in pain, you're not going to open the VDO immediately, because that's not going to be comfortable for them. That's where your diagnosis, making the appliance with maybe a neuromuscular phonetic bite to get them comfortable, get them out of pain, and then evaluating where they're at, and if they need a vertical for their MAD. Yeah.
Got it. John asks, what are the reasons you'd avoid an anterior discluding element?
Actually, to be honest, I don't do them that often. They're not one of my go-tos. And what I found is where I've added them on patients, funnily enough, 50% I've removed.
Got it. Do class 3 folk, Paul asks, do class 3 folks need any mandibular adjustment before doing the bite because they don't go forward very much?
It really depends on what the patient's whole goal is, right? So if you're only addressing sleep, you're not going to do a mandibular adjustment for a sleep appliance. But if you are talking about to the patient about the way they function, they look, and it's a bigger picture, and you want to do something different before, yes, absolutely.
Cool. Tony said that he thought you offered a comprehensive airway package, but you also submit to insurance. Can I answer that one succinctly?
Mm-hmm.
She started with insurance, Tony, and then went to private pay. So the airway package that Dr. Patel goes through in detail in the course, that's actually for fee for service or bill as a courtesy after the fact. Whereas if you're billing insurance with all of the codes, it's going to be important to track the actual insurance codes that you're submitting versus dummy insurance codes to just track it in your dental management software. Okay, so we got mystery in the history. Can you restate the 4 reasons that people brux?
Sleep disorders, stress, medications, SSRIs, and the stability or instability in joint muscle.
Awesome. Cool. Do you see restorative patients during the same time as you see your sleep patients?
When I first started out, it was really difficult to go from dentistry to sleep. And so what we, because you're learning and you don't have a flow, everything's just starting out. So what we did as a team is we just booked off one little afternoon for sleep. And then it became a day, and then it became 2 days. And then when COVID came, my restorative assistant didn't come back. She retired from dentistry. And so what happened was then my sleep queen became my restorative in sleep. So we had no choice but to meld it all together. But by that time we had such a great flow that I was able to see restorative patients, and she would do my follow-ups in sleep and in data gathering. And then I would work with one of the front desk or ISAVAC.
Yep.
Yeah.
Paul, you said it makes sense, and it's difficult to know how long sleep appointments take. Thank you for the feedback. I would say that probably opens up the whole conversation about workflow and having really predefined roles of who does what, how long appointments should take, and really dialing that in. again, if that's something that you guys want to learn more about, we do talk about that workflow and appointment times very heavily in the weekend course that there's a special for. If you're talking about the clinical exam and delivery appointments, those are the clinical course. But yeah, that standard, and then meld it to what you actually do in the practice based on those roles.
Yeah, and I will tell you the goal, like, did I want to do every single thing with sleep at the beginning? Yes. And then I realized that that's not going to be productive for my practice. But when I actually sat down and went through my process, out of maybe the 7 appointments from start to finish, consult for the sleep, test, the records appointment, all of those things, the delivery follow-ups, I ended up, once we had our thing down, maybe about 45 minutes with my patient.
Yeah.
The whole time. Yeah. So it's got to be team driven, and you got to have a really well implemented process for your team to take over.
Well, we are getting some goodbye waves from people in chat, because we are at almost 9. We're pushing 9:20 East your time.
Yeah.
So thank you all for a great night. Dr. Mona Patel.
Thank you, everyone.
You're awesome, as usual.
Thank you for spending time with us. Yeah.
So watch your emails, y'all. You'll get an email within 1 hour. So by 7:19 p.m. Pacific, 8:19 Mountain, I'm just kidding, all the way up to 10:19 Eastern. Give us an hour. We're going to get the email out to you. It'll have the link for the CE and the link for the studies, and a link to a coaching consult or the course if you guys want to take advantage. Hey, we appreciate you guys. You are the reason why we do this, and we had a blast tonight. So thanks so much. Have a good evening.
Thank you, everyone. Have a wonderful evening.
All right, Mona, I have to tell you,